Hey, are you a business owner, entrepreneur, or professional? If so, we want you to apply to be a featured guest on our show. My name is Adam Torres, and I host the Mission Matters series of podcasts. I've recorded over 3,000 episodes, and we are just getting started. How do you know if you'd be a good guest to be on the show? Well, only one way to find out, and that's to apply, but I'm going to let you in on a little secret. We want guests that have a story to tell, guests with a brand, a product, or a service that can benefit my audience of listeners. If this sounds like you, go to missionmatters.com and click on Be Our Guest to Apply. I'd love to talk to you and get to know more about your story. Again, head on over to missionmatters.com and click on Be Our Guest to Apply. All right, now let's get into the show. Hey, I'd like to welcome you to another episode of the Mission Matters podcast, your source for all things business. My name is Adam Torres, and if you'd like to apply to be a guest on the show, just head on over to missionmatters.com and click on Be Our Guest to Apply. All right, so today I have Michael Follick on the line, and he's CEO over at Abacus Health Solutions. Michael, welcome to the show.
Thank you very much. It's a pleasure to be here.
All right. So I'm excited about today's topic. So we'll talk about Abacus Health Solutions. We, of course, are going to get into the study that was published recently for your company, which is it's pretty groundbreaking and it's exciting because we finally have some measurements that weren't necessarily always in place. So we'll talk about that, of course, and also just healthcare in general. I mean, it's rare to get somebody on the line that's been working in the field as long as you have, and that also has a really unique perspective on the angle, especially in healthcare, from a healthcare provider side, from the patient side. I mean, you're really covering this from every single angle with what you were tackling. So I think maybe just to get us started, just a little bit of your background and really how you got started on this journey would be helpful.
Sure. Well, by profession, I am a Ph.D. Clinical psychologist. And so our role and my focus over my career has always been the relationship between behavior, health, and illness. Not much mental illness, mental health that most clinical psychologists focus on, but mine has been the relationship between physical health and illness and behavior.
And so when you say this, I want to build this further out. So when we think about the healthcare system in general and what you're going after, or I should say what you're focusing on, right. Give us a little bit more context into what that means.
Sure, absolutely. Our mission, and it's been for quite some time, has been to show the relationship between behavior, health, and illness. So in the early years, we were focused on establishing that there is a relationship between behavior and disease. As medicine has gone through a major transformation. You know, in the 40s, 50s, and 60s, it was a biological model. Yeah. It was dealing with diseases. Typhoid, smallpox, diphtheria, these things all responded to a straight biological model, and which means you can treat it with usually a single biological intervention. But as we started to extend the life expectancy for Americans, Americans started to develop chronic diseases like heart disease, lung disease, diabetes. And as these diseases became more prevalent, medicine needed to realize that it needs a broader model than a biological model. It needs to move to what's called a biopsychosocial model. So more factors influence a disease, both in terms of how it gets developed and in terms of how it gets managed. And so our mission has been to establish the relationship between behavior and disease, and then also the role that behavioral science plays in altering those behaviors that relate to either the development of disease or the management of disease. Today, most America is fairly familiar with the wellness movement. That really came from the early days where we showed the relationship between behavior like exercise, smoking, diet, those things, and disease like heart disease or diabetes.
What fits under the umbrella of behavioral science? Just to give us a feel for it.
Well, there's two parts of it. I mean, the first part is establishing the relationship between behavior and disease. But the second part is the principles of behavioral science are how to basically modify behaviors. Most people that are familiar with the two classic models, one is the Skinnerian model, which is more of a behavior change model, incentives and rewards and things like that. And the other is a classical conditioning model, more like a Pavlovian model. Mm-hmm. And as behavioral scientists, we believe that what's most applicable is the Skinnerian type model, where the basic principles of behavioral science are, you just like you raise your kid, you train your dog, they're all principles of behavioral science. Your wife manages your behavior, that's all principles of behavioral science. You monitor the behavior, you give feedback on the behavior, and then you give incentives on the behavior. And pretty much the world runs on those basic principles.
No, I think that's a great comparison. Everybody's watching this right now is like, oh, so now she thinks she's a behavioral scientist. Great.
Yes, they are. They have
powerful
reinforcers in the world at their disposal.
Oh, that's awesome. So I want to let's move a little bit further into how the behavioral. We talked a little bit about the behavioral sciences, a little bit about the evolution. Like, how does this affect our systems overall? So like healthcare, like, because this is all evolving, and as the science evolves, like the way that all the different pieces that are connected do too. So like, what are you seeing?
Well, what happens is, let's assume, first of all, let's focus on diabetes for a second, because diabetes is a very prevalent condition, and it's very highly, particularly type 2, is highly related to obesity. So as the obesity epidemic in this country continues to spiral out of control, the occurrence of diabetes is going to continue high. And so you go to a doctor and a patient gets diabetes, they go to a doctor and the doctor says, okay, you have diabetes, here's the things I want you to take, and here's the things I want you to do. And there's a whole lot of things you have to do. You have to test all the time. You have to match your dietary intake with your glucose levels. It's a very complicated disease. And the problem is, later in life, you're going to develop complications if you don't manage it early on. So those delayed outcomes are tough, because you're doing things today that you're not going to get some of the outcome on until later. And that's tough. So basically, in the case of diabetes, the doctor says you have it and this is the medicine, but you also have to engage in these behaviors. And not everybody engages in the appropriate behaviors. In fact, probably less than 10% of diabetics, type 2 diabetics, follow all the evidence-based standards of care as published by the American Diabetes Association. So these are specific behaviors that every diabetic needs to follow, like biannual A1C, annual eye exam, annual foot exam, blood lipid levels, urine proteins. These things need to be checked every year routinely. And you need to test regularly, and you need to take your medication regularly. It's a complicated process. So the patient has to be engaged. And if they don't exhibit those behaviors, they're not going to have good health outcomes.
Mm. And so, and just to be clear, so then this, what could be pretty treatable, let's just say, or prevented some of the bigger things that happen down the line, like if left untreated, then when this does come up, like big things happen, right? Like that's when it's like life threatening, or, losing limbs, or like other things that are really big. Am I right on that, or?
Absolutely. Yeah. Unmanaged diabetes can have serious consequences, such as loss of eyesight, loss of sexual functioning, loss of limbs, all kinds of peripheral neuropathy. There's all kinds of consequences to diabetes. And diabetes causes tremendous amount of disability associated with it, but it also has a tremendous cost associated with it. So as those complications occur, the costs drive up. So diabetes as a category, if you look at healthcare costs, let's assume you look at an employer's health plan, 20% of their spending is on diabetes-related conditions.
Wow.
Even though diabetes as a frequency of occurrence is probably only about 5 or 6%. In some cases, it's as high as 10. But it's 5 or 6% of the population accounts for 20% of the spend.
Okay, so that's significant. I want to switch it up a bit. So I want to get into Abacus Health Solutions and really how you're working to combat some of the things that we've been talking about so far.
Absolutely. So as I indicated, our mission has been to show that behavior is important in our healthcare system. And we have hypothesized that if we increase patient engagement in the management of their condition, we're going to get better health outcomes and lower healthcare costs if we can increase patient engagement. And by increasing patient engagement, I'm talking about making sure they see their doctor regularly, making sure that they do all their steps, their biannual A1Cs, their annual eye exam, their annual foot exam, all the steps that they need to follow, as well as their medication adherence. We're going to get better health outcomes for those individuals, ultimately lower healthcare costs for the plans. And so we set out to configure a system. It's a technology platform where it's voluntary and individuals can voluntarily choose to participate. But if you join, we will monitor and give you feedback on the steps and the time that you have to complete within a certain time frame. And one of those additional steps is what's called a diabetes health action plan. You complete this telephonic interview where our diabetes nurses and our pharmacists basically help you create a plan for yourself to improve your diabetic condition as well as those steps. And if you're adherent to those steps, you follow those steps every year, we basically give you an incentive card, a get out of jail free card, I call it, which means that when you go to the pharmacy, you hand them this card and you have no copays or any out-of-pocket expenses for your diabetic medications or supplies.
Wow.
So there's the reward. There's the incentive for good adherence and engagement. And what we have found, both in case studies after case study, and now when we talk in a minute about the study, I'll elaborate with the study, we found that we can improve patient engagement significantly. And we can actually improve health outcomes and lower healthcare costs.
That's a big deal.
It's a very big deal.
It's a big deal.
So we lower it for the individual too, because they have no out-of-pocket copays.
Yeah.
And the diabetic is probably going to spend 80, over 100 a month out of their pocket. That's a big deal.
What is the and I know this may vary, right, depending on the patient, depending on so not asking you to give me medical advice, of course, but what is like the user experience? So let's just say that I'm watching this right now, I'm thinking about it, and I'm like, oh, Abacus sounds like a really interesting company. Like I could possibly use this. I've been trying, and I've been maybe struggling on this path, and maybe this is something that I can use. Like, what does that user experience look like to be onboarded, or however we would word that properly?
Absolutely, that's fine. We strive to make the user experience very helpful and very supportive. This is part of an employer-sponsored health plan, so we don't just take calls from individuals. Yeah, it's usually sponsored by an employer health plan, and we put it into the plan as a benefit to their members. So if their members are compliant with the program, they have no out-of-pocket costs for their diabetes. And we try to make sure that we support them, and we use whatever medium they want. If they want to be supported telephonically, they have call lines they can call into, as well as we do outbound calls. We do text messaging, we do email, we do whatever the individual finds most comfortable for them. We do. And there is a whole staff of people that can support you outside of the doctor's office to make sure that you understand what you're supposed to do and understand the management of your diabetes as well as follow through with the steps you need to take. So it tends to be a fairly easy experience, and it frees the doctor up to prescribe whatever medications are best for you. Like some medications are only taken once a day, others are taken 3 times a day. So whatever medications and plan works best, the doctor can prescribe it, and you can set it up for you.
All right, Michael. So talking about the patient experience. So like, how does this affect the whole family unit? Because I know different family members may be affected by diabetes and maybe some aren't. Like, how does that play into this? Great question.
In general, we found in this country that women tend to be the primary influencer of healthcare for a family. They're the ones that actually influence the other members of the family to do what they got to do. One of the advantages of the program, let's assume that the spouse of the woman is the employee and her spouse has diabetes. They oftentimes struggle to get them knowing what they need to do, to get them to do it. In this instance, we provide a lot of support for that spouse in the sense that we help their husband follow through with the steps that he needs to follow through. So it ends up helping the family dynamics a lot, because then the woman isn't the policeman. We help take some of that burden.
No, that's awesome. It makes total sense too when you say this. That it just makes sense. Now they're not the bad guy, so to speak, saying, "Hey, you have to go do this." It's more like, okay, if we do this, then we don't have to pay our copay or XYZ or anything else. So then it's not like come on, let's do it.
Exactly. And now we got money to buy Johnny's hockey skates or Beth's figure skates, whatever the case may be.
Totally. Now there's also many employers, so business owners, entrepreneurs, executives that watch this program. What's typically from the employer side a good fit? Is it like size of company? Is it revenue? Or is it like composition of plan? And again, just high level, because I know healthcare plans can be pretty technical.
Right. No, that's for sure. But most of the time we work with self-funded health plans. So it's employers that are not buying the insurance per se, they're buying an administrator, but they're paying for all the costs themselves. And that typically tends to be a relatively larger employer, usually 1,000 or more. Mm-hmm. If you get into concerns about privacy and protected health information, if you have too small of a health plan number and there's only a few diabetic. Mm-hmm. So, and we find a lot of unions really like this because it enables them, as they've had to give up ground on copays and deductibles, allows them a way to kind of give something, make sure their membership gets something for free if they follow through with the process. So they tend to like it a lot. But the employers, there's a real business case here. And the reason for this study was to document the business case in a statistically controlled context. This can produce a significant ROI. In fact, we just had one customer where we just met with them and we saved them $8 million last year. Customer. But there's a real business case for this kind of thing. You're not just giving a benefit away for no reason. And that doesn't count. That's direct costs. That doesn't count the indirect costs associated with lost productivity and a lack of presenteeism.
Let's go further down the line of the study, because this is a big deal. Okay. Just published. So behavior-based diabetes, behavior-based diabetes management. So tell us why this was such a groundbreaking study, and why, in my opinion, it's setting a new bar for this I guess, for making the case on it being a real, bottom line, something that can affect the bottom line, as opposed to just being something that we want to do or we should do.
Right. It's proven now. It's scientific. Credible. Basically and there's many over the years, everybody claims that they can change this and save employers money. I mean, employers are constantly barraged with people saying, I'm going to save you all this money. I'm going to save you all this money. And they never do. And so people have become skeptical over the years. So you really look for proof. Now, we did a number of case studies. So we had a number of case studies where we go in, work with an employer, set up the program, and not everybody, and here's important how we evaluate it. This is an important. Not all diabetics join the program. We typically about 40% on average of the diabetic population of an employer self-funded health plan who joins the program. Now, that's higher than most anybody other programs get by far.
For sure.
3 to 4 times higher. But we then look at the total spend of the diabetic pool before our program is implemented and the diabetic spend after it's implemented. And diabetes tends to have one of the most rapidly escalating cost curves among health conditions. So it grows faster than health inflation every year. It grows faster than the norm on health inflation. And so we actually run the program and we take the total cost before and after, and we found that we actually reduced trends. We turned them down. We actually saved money. We not only some actually is directly less spending the year or two after we did it than before. That's all good, but you go and promise an employer that, and they say, well, how do I know that's not just a statistical anomaly? That's just not, happenstance.
Of course.
And so we run multiple case studies, and still they say, how that isn't chance. It could be chance that you get 10 of those in a row. That could be chance. You wait. Well, that's true. That's the way we look at medicine too.
Of course.
The way you get around that is you say, okay, show me a controlled scientific study. A typical controlled scientific study is one where you would randomly assign into group A or group B or whatever you've got, and you do random assignment. It's hard to do that here because you can't just say you're going to get treated and you're not going to get treated.
Yeah.
So what we've done is the next best thing, which is called a match control group study. So we took 8 years worth of data. There was 14,000 diabetics. And we took the group that was treated and we found a matched control group for them. And they were matched in a very elaborate and sophisticated way on age, sex, demographic area, or zip code. They were matched on what's called a Lex-Hauser index, which is a severity index for their condition. They were matched on whether they were insulin using or non-insulin using. Very complex matching procedure. We ended up with 300 people that were matched. And when we compared the treated group that were in the program to that matched control group that wasn't, we had very significant differences, all statistically significant. Found that they had significantly more, the group and the people in the program had significantly more doctor's visits, significantly higher medication use. They had a greater persistency of insulin use. They were 80% more likely to use their insulin.
Wow.
It was amazing.
80 is a big number of anything.
80 is a big
Any
number.
behavioral change. I don't care.
But particularly insulin use, you know, very important piece. They had many fewer gaps in care. They completed far more of the things they were supposed to do.
Wow.
Every year than the others. Like they were 38% more likely to complete their biannual A1Cs. So we found those to be true. We found actually they had better A1Cs, which is your marker of diabetic control. And there was a 20% reduction in people who were out of control by the time they completed the program. The more important thing from the employer, from a business case point of view, there was 38% fewer hospital admissions in the treated group than the match control group. 38%, that's a big number. That translated to 20% less on a per member per month cost for the group. So we were able to show that those health improvements, which followed the theory that better engagement yields better health outcomes, you have more medication use, better health outcomes, lower cost. That's the theory that everyone's been working on that worked in the quality arena, and we're able to show that that's true. If you focus on the right behaviors, you have right behaviors targeted and incentivized. So it's a big deal, and now we just passed validation from the Validation Institute, which is a division of the World Congress, an arm of the World Congress, saying these people actually can produce what their marketing materials say they can produce.
Wow. Well, first off, congrats. This read like hearing your story, to me, it reads like a Malcolm Gladwell book. I'm sitting here like, what's next? Awesome.
Well, thank you. That's very kind of you. And the study was just published in the American Journal of Managed Care. And if I can, we've been looking at managed care for years, and CMS did a large study on managed care and should it be part of everything. There was really no scientific evidence that you could produce an approach to managed care that saved money and produced better health outcomes. Most managed care is just nurse call lines and things like that, where people get calls and prompts. This study shows that if you structure it properly using the principles of behavioral science, you can in fact get better health outcomes and lower cost.
That's amazing. What's been the feedback from just the community, like in large, whether it's the healthcare side, the patient side, the employer side? I mean, this is a big deal.
Thank you. Most of the feedback that we're getting is very, very positive and very supportive. You find initially people are skeptical. I think if I'm an executive of a health plan, they all go, everybody promises to save me the money and nobody can.
Yeah.
So I think we're going to see now a shift in the way we start even approaching our approach, in the sense that we're going to take less money up front and take more of the savings. So we actually are more linked to exactly your outcome and your performance. We're not just, the financial risk isn't all based on the employer. So we're starting to migrate our models to be more back-end based than front-end based for reimbursement. And not many people have been able to do this kind of thing because most people don't have the staying power, the financial staying power to support research for that long. Well, fortunately, because of our background as former academicians, we were able to get some supplemental support from the feds to do SBIR research. And then we had our own capital. So we weren't answering to anybody but ourselves. And our mission was to prove this to be true, no matter how much profit.
Is awesome. It really is a great story. So what is this? I mean, you said, for example, the implications of you mentioned earlier in the interview, maybe you save one employer, I think it was $8 million. So that's very significant for an employer, of course. What about, like, let's talk about overall healthcare system as we're just thinking about different models, different plans, and what diabetes costs, for example. Like what kind of implications do you see? Like if we're just dreaming for a moment, as this catches fire, as this keeps on growing, and as Abacus Health keeps on doing great work, I mean, what do you see?
Well, that's a great question. And I think that hopefully we're going to see more of a focus of plan designs change to basically incentivize people to engage in the appropriate behaviors. Because actually right now, health plans have created kind of a disincentive to fill your medicines because, those are barriers. You have co-pays and deductibles, and everybody says, well, if they get skin in the game, then they'll be incentivized to do it. Well, the problem is if you put too much skin in it, it's too much of a barrier. It starts competing with the financial demands of your family. Many people will put their financial demands of their kids ahead of their own health needs.
Sure.
That's not uncommon. And so I think we're going to need to see a shift in the way we do plan design, hopefully to become more behavior-based. And then we'll have more targeted approaches to patient engagement for the appropriate behaviors. And, a lot of people have been trying to say, well, let's just incentivize the docs to do this. Docs can't make patients come back to their office.
Yeah.
All my colleagues in primary care say, look, I can get about 50% of them in, the rest of them, I can't get them back.
Yeah.
So we're actually driving from the other side, driving the patient to the doctor. That's going to be an important next shift that we're going to have to make in the structure of our healthcare system.
I love that you said that, by the way. So first off, for sure, hats off to the doctors out there. They're already busy to try to they're not, and no offense to the medical schools, but they're also not salespeople. Like they're not here to cold call you to get you back into the doctor's office. They did their part of the deal. You have to go back in too. But that being said, I love what you're talking about, the behavior-based, thinking about how that works into plan design, because in theory, like in a perfect world, that's how it would have always been, right? Like the idea is like, if we can get the want to do and to want to treat themselves and to want to be healthy. It's not saying nobody wants to be healthy, by the way. I'm not saying that, but if we can get the factors to align to create the right outcome of behavior that makes somebody healthier, that eases the burden on the healthcare system, that eases the burden even on the doctors, like the doctors that say that they can get 50% of their patients in there. They don't want to see, I mean, their heart's in this. They don't want to see, they told their patient to do X, Y, Z. They didn't. Unfortunately, they didn't see them in a year or so. And now when they come back in, maybe they're losing a foot, or maybe they're losing like something worse, or maybe they're like past the point of you just have to eat right or do X, Y, Z, whatever the diagnosis was, right? Then they're past that point, and now they have to treat something that's much more serious. Like the doctors' hearts are in this too, and they want to see the validation of the patients getting better. So it just seems like heading down this direction is just good for all parties concerned.
It is. And actually, we've had doctors write us letters and say, hey, thanks. I appreciate this program actually drives the patient to me and makes them bring in a plan for their health improvement that we review together. They go, I love this. Thank you very much. The other thing that this intersects with is not only supports the doctors, but it intersects with something called value-based plan design. People were promoting the value of pharmacy, and that if you use pharmacy more systematically, you would get lower healthcare costs. You would avoid some hospitalizations. Well, what we've done is we've made it strategic, where you're not just giving medicine away, giving the medicines that are needed away for the right behaviors. And that's taken a value-based plan design approach to the next level. And just like we've done with managed care, you've taken it to the next level because you've made all the incentives are very specifically tied to behaviors. And they're the behaviors, the evidence-based standards of care. And that's really what evidence-based medicine wanted to see happen.
Can you give just to put some meat around that? Can you just give an example of one of these how the reward system works? And it could just be one, but just an example.
From our approach, or are you
Yeah,
talking?
from your approach. So you're rewarding the correct behavior with the correct
Correct.
medicine. So can you just give us an example of what the correct behavior would look like?
Absolutely. We're rewarding it with the avoidance of cost for the medication. So if the correct behaviors are, let's just say you take within a 12-month period, you have so much time to complete this. You have to do your diabetes health action plan. You have to have your doctor's visits. You have to have your biannual A1C, your annual exam. It's a whole list of steps.
Yeah.
To complete all those, you are rewarded with the incentives. Now, some incentives are just money, but most of the time they're copay waivers. And that's how you earn your copay waivers, with those specific behaviors, because nobody's tracking the patient in the general healthcare. No one's tracking you to see if you're getting that stuff done, because typically you leave your doctor's office to go get an eye exam, and they don't know you got that eye exam.
For sure.
Or you're leaving to go see a podiatrist, and they don't know whether you got that. And they only look in the labs and say, oh, gee, I need you to go get labs. They want all that stuff ahead of time at the right time. Precision medicine is what we have to have, and that means you got to get the right thing at the right time for the right person.
Love it. So it's almost like you're almost like gamification, like you're making it into something where you have to hit this new level to earn this reward. You have to do X, Y, Z, which everything's in your benefit. You're not telling anybody to do anything that's wrong.
It is like gamification, but in a sense, you're not in a draw. You're actually getting the reward. You're assured the winning of the game if you do these steps.
It's awesome. So Michael, I just have to say it has been a pleasure having you on the show today. And you taught me a lot today about what's going on. And I know my audience too learned a lot. That being said, if somebody's watching this and they want to learn more, maybe they want to read the study, or maybe they're an employer looking at things. What's the best way for people to connect with Abacus Health Solutions overall?
Probably the easiest to go onto the website and reach out to us through the web portal. It's Abacus Health Solutions. AbacusHealth.com is what they go to. And so
fantastic. And we'll have all that in the show notes, of course, and all that good stuff. So our viewers can go in there and just click on the link. So again, Michael, it's been a pleasure having you on the show today.
Pleasure.
And
pleasure's all mine.
And to the audience, as always, thank you for tuning in. I hope you got a lot of value out of this. Hope you learned a lot. If you did, don't forget, hit that subscribe button. We definitely want you to be a return listener or viewer, depending on where you're at with us today. And Michael, until the next time, thanks again for coming on.
My pleasure. Thank you.